All right, good afternoon, everyone. Thank you so much for the warm introduction, and thank you all for being here. So as stated, I'm Kim Lewis. I'm an assistant professor of McMaster and an adult intensivist at St. Joe's. And I am so thrilled to be here today to provide you with an update of the guideline that we all affectionately know as PADIS, which stands for Prevention and Management of Pain, Anxiety, Agitation, Sedation, Delirium, Immobility, and Sleep Disruption in Adult Patients. There's a QR code down here on the next two slides, and if you take your phone out, this will take you to a direct link to the guideline that's published in CCM a couple of days ago. In terms of conflicts of interest, I do have a national grant to perform an RCT examining sedation, specifically dexmedetomidine use versus placebo during non-invasive ventilation. All right, so unfortunately, most ICU patients will experience pain, anxiety, agitation, delirium, immobility, and sleep disruption at some point in time during their ICU stay. And if we don't try to mitigate those, recognize and treat these cluster of symptoms and issues, there is an increased risk of morbidity and mortality. And in fact, SCCM has already published 2 evidence-based practice guidelines to help us manage this. There was the 2013 PAD and subsequently the 2018 PADIS guideline. Since the release of this fantastic guideline by John Devlin et al., there have been several relevant high-quality RCTs that have been published. As such, we're asked to update the PADIS guideline. So first of all, there was a diverse panel of 20 subject matter experts that included physicians and nurses and pharmacists and physiotherapists and psychologists, as well as 3 ICU survivors that were with us from start to end. We were led by our fantastic chairs, Michelle Bayless, who is here, and Matt Aldrich, who I think is running off a plane and may come in the middle of the presentation. And then also our co-chiefs, and our sub-chiefs, I guess, is Joanna Stalling, who's in the audience, and Molly McNett as well. So grade methodology was used throughout, as opposed to the 2018 PICOs where they had 37 recommendations. We were allowed to have 5. So through that, we had to prioritize which PICO questions we were going to update. As such, as a team, we decided to update elements of the 2018 PADIS guidelines that had new evidence published. So I'm sure many in the room will know that there were new landmark trials published on dexmedetomidine, antipsychotics, immobilization, as well as melatonin. So those were topics that we updated. And also, we wanted to address clinically relevant topics that had not been addressed prior, and anxiety was selected. We then performed systematic reviews and meta-analyses, and we then graded the certainty of evidence, and then in the sub-panels for each individual PICO, issued a draft recommendation. And that draft recommendation was then presented to the panel at large, and those that were free of overt or potential conflicts of interest voted, and we had a 100% response rate. I'm very excited to share with you some of the recommendations. All right, recommendation, the first overall heading is anxiety and benzodiazepines. So we know anxiety is a common and very distressing symptom of patients that are admitted to ICUs, and benzos are commonly used to treat this acute anxiety. So naturally we asked, adults admitted to the ICU, do benzos administered for anxiety compared to no benzos impact patient outcomes? This is very anticlimactic. There were no studies that directly answered our PICO, so we were unable to issue a recommendation on the use of benzos to treat anxiety in patients. However, this really is a call to action of everybody in the room right now. This is an understudied, distressing symptom without a ton of management. So everybody, this should be on your research radar. And I actually think there's an RCT that's being presented right now on propranolol anxiety at the same time. So hopefully this will get the ball rolling. Okay, next overarching theme is sedation. We asked in mechanically ventilated adults admitted to the ICU, should dexmedetomidine, when compared with propofol, be used for sedation? In total, we identified 29 RCTs with 3,087 patients that looked at dexmedetomidine versus propofol in adult patients that were intubated and sedated in the ICU. Of note for you, 22 of those RCTs titrated their medications to achieve light sedation. And what did we find? There was a moderate reduction in risk of delirium for the patients that had received dexmedetomidine compared to propofol. So about a 45% relative risk reduction, or you can think about it in absolute terms, and that would be out of 100 patients, 15 fewer patients would have dexmedetomidine if they were treated with, or 15 fewer patients had delirium if treated with dexmedetomidine compared to propofol. And that was a moderate certainty of evidence. In line with that, we also found there was a reduction in the duration of delirium by about a day, a little bit more actually, so 25 hours shorter, ranging from almost 2 days to about 8 hours, and this was a low certainty of evidence. Other things we found, so there may be a slight, and I do emphasize slight, reduction in duration of mechanical ventilation and ICU length of stay. Kind of at the best of times, 3 to 7 hours, so very slight. Is that clinically relevant? It likely reduces the need for supplemental analgesics, though, and this was a moderate certainty of evidence, which is not surprising because we know dexmedetomidine has important analgesic properties. There was no effect of mortality at longest follow-up. And then, as is everything we do and give in critical care, there are risks as well. So it likely increases the risk of bradycardia. This is a moderate certainty, ranging about an average of 5 more patients per 100 would get some bradycardic events. And there may be an increased risk of hypotension as well. So overall, we suggest using dexmedetomidine over propofol for sedation in mechanically ventilated patients admitted to the ICU where light sedation or delirium are of the highest priority. And notice that I use the word suggest as opposed to recommendation. So this is a conditional recommendation overall, which means that most patients, you probably want to follow the recommendation, but not everybody would, and you have to use your clinical judgment there. This was overall moderate certainty of evidence. And anytime you see one of these little yellow alert pictures, it means that this is a change from the 2018 PADIS guidelines, and this was a change. In 2018, they suggested using propofol or dexmedetomidine over benzos for sedation, and this reflects the fact that they only had 3 RCTs compared to the 29 RCTs that we identified. So that is a change. So overall, again, this is a conditional recommendation, and you need to use clinical judgment. Patients that have a high risk of developing bradycardia, maybe dexmedetomidine isn't the right answer, maybe propofol is a better answer. Also, those that need deep sedation, again, propofol is probably the way to go. It was also a conditional recommendation in that the cost and acquisition of dexmedetomidine may be prohibitive in some centers. I know, for example, in Canada, although much cheaper than it is still far more expensive than propofol, so it may not be the solution for everybody. All right, moving right along, we are going to go into the overall arching theme of delirium. And for this, we asked in adults admitted to the ICU, do antipsychotics administered for delirium that occurs at any point during their ICU stay compared to no antipsychotics impact patient outcomes? So this question is really saying, do antipsychotics treat delirium? Overall, we identified 8 RCTs that addressed this question, and this was 1,869 adults that looked at antipsychotics compared to no antipsychotics. What did we find? We were a little bit surprised with. So from all of that, we found there may be a slight reduction in mortality at 28 days. The relative risk reduction was about 13%. If you look at the absolute risk reduction, that is 4 fewer patients out of 100 may have a better survival if you give it an antipsychotic compared to not, with the caveat that this is low certainty data. Likewise, with mortality at the longest follow-up, there was about 11% relative risk reduction and the same absolute risk reduction of 4 patients out of 100 having less death. And again, low certainty of data, meaning it may be the answer, but it could also not be the answer. Other things we found, there may be a slight increase in delirium-free days, so that's good, right? We want more delirium-free days. About 1 day is what was found. Again, low certainty of data. And we found no effect on duration of invasive mechanical ventilation, ICU length of stay, and hospital length of stay, and uncertain effects on duration of delirium. Again, those risks and benefits We found there may be a slight increase in arrhythmia, but no effects on QTC prolongation or extrapyramidal symptoms, all low certainty. So overall, we were unable to issue a recommendation for or against the use of antipsychotics over usual care for the treatment of delirium in adult patients admitted to the ICU. Again, this is conditional recommendation, and this is a change from the 2018 PADIS guidelines, where they say they made a recommendation against using antipsychotics for the treatment of delirium. And I'll get into all of this now. So, the panel was unable to issue a recommendation for the use of antipsychotics to treat delirium, despite this possible reduction in mortality and possible improvement in delirium-free days. Why? Well, first, all the potential benefits were of low certainty. So it may be the answer, but again, it may not. It means we're not terribly certain in what we found with the data. And second, we don't actually really understand how an antipsychotic could result in a reduction in mortality when the only change we saw was a one-day improvement in delirium-free days, but no other outcomes like duration, mechanical ventilation, ICU length of stay, et cetera, had an effect. So that will be the most controversial one. Moving on. Immobility. Okay, so in this PICO, we were asked, in adults admitted to the ICU, does enhanced mobilization or rehabilitation, which I will just say mobilization because it's otherwise a mouthful, compared to usual care mobilization, impact patient outcomes? So we know mobilization in the ICU is aimed to mitigate the long-term effects of ICU-acquired weakness. But how? How do we do that? We really don't know how often we should be doing it, what intensity should we be doing it with, for how long should we be doing each one. How do you do it? Is it stepping or cycling or protocolized? We really don't know the answer. For the purpose of this PICO, just so everybody knows, we define mobilization as the process of moving oneself and changing and maintaining postures, and we excluded pulmonary rehabilitation. And we also defined enhance as anything more than a unit's usual mobilization, i.e., usual care had to include some amount of mobilization. So again, this could have included cycling or stepping or early or twice daily or extended duration or protocolized mobilization. So it was a little heterogeneous. In total, we found 58 RCTs that compared enhanced mobilization to usual care, and this was 8,000 patients in total. What did we find? Unsurprisingly, we found that enhanced mobilization compared to usual care results in a reduction in ICU-acquired weakness, and this was high certainty data. What else did we find? There were other benefits. Like there may be a slight reduction in duration of delirium, and this was about 1.5 days shorter, roughly, low certainty. It may reduce the duration of invasive mechanical ventilation by about a day. This is moderate certainty. It may reduce ICU length of stay by about a day, low certainty, as well as hospital length of stay by about a day, again, low certainty. It also can improve the number of patients that are being discharged home. So 8 more patients per 100 if you used enhanced compared to usual mobilization will go home as opposed to rehabilitation, for example. It certainly improves their functional ability and improves their quality of life, both of those with moderate certainty. There was no effect on mortality at longest follow-up. Obviously, risks and benefits, here we are again. So there was a slight increased risk of adverse events, a slight increased risk of arrhythmias, both one more event compared in 100 patients, so not that frequent or large. And we found no increased risk of unplanned extubation, because who wouldn't love to extubate someone in a hall that's standing up? And no increased risk of accidental line removal, and those were both moderate certainty of evidence. So based on this, we suggest, again, so suggest being conditional as opposed to a strong recommendation, providing enhanced mobilization or rehabilitation over usual care mobilization to adult patients admitted to the ICU. Conditional recommendation, I'll say again to why, because it seems like there's a lot of benefits there. Moderate certainty of evidence, and this is a change from the 2018 PADIS guidelines that we're seeing with that exclamation mark. In 2018, they suggested performing rehab or mobilization in critically ill adults over doing nothing. So Tell me about the conditional recommendation, you may be saying. Well, the benefits of enhanced mobilization certainly seem to outweigh the marginal risk of an adverse event, which seems to occur infrequently. However, what we found is no RCTs reported on the required resources for an ICU enhanced mobilization program. And the panel issued a conditional recommendation understanding and recognizing that resource limitations can be a very significant barrier to implementing such a program. So being on the side of cautious with that. And then in addition, we're not really helping you. We're saying do something, but it was so heterogeneous with what was done, how often it was done, the intensity that it was done. So we weren't able to issue a recommendation on the absolute ideal way to do it. Okay, last one, sleep disruption. So our PICO for this was in adults admitted to the ICU, does melatonin compared to placebo impact patient outcomes? In total, we identified 30 RCTs with 3,739 patients. 27 studies looked at melatonin to placebo usually, 3 that looked at Ramelteon. What did we find? So we found moderate certainty that melatonin would not improve the sleep quality. We found very low certainty of evidence, which kind of means we don't know if it improves the number of awakenings. And there was a low certainty of evidence that melatonin compared to no melatonin will improve the sleep quality. What we did find, which I don't know if we were expecting, was that melatonin may reduce the amount of delirium that we see. So there was about a 30% relative risk reduction in the number of patients that had delirium when melatonin was given compared to not. And if we look at that absolute risk reduction again, it was 9 fewer patients of 100 would not have delirium. Other outcomes we found, there was a slight reduction in ICU length of stay. It was about a half a day lower when you look at the point estimate. This was a low certainty. There was a slight reduction in adverse events compared to usual care. Melatonin is relatively safe. If you look at the product monograph, it's usually like daytime sleepiness is the most common adverse event you can see. There was little to no difference in duration of mechanical ventilation or hospital length of stay. Those were both low certainty. So overall, we suggest administering melatonin over no melatonin in adult patients admitted to the ICU. Again, it's that suggest word, which means that this is a conditional recommendation with low certainty evidence. And this is a change from our 2018 PADIS guideline, in which they were unable to provide a recommendation on the use of melatonin. And this is guided by the fact that there were only 3 RCTs published when they did the first guideline compared to the 30 that we saw now. Pardon me. So why conditional recommendation? A conditional recommendation favors melatonin because of the reduction in delirium and potential perceived improvement in sleep against the low risk of adverse events. There were limitations. Again, this is why this is a conditional recommendation. Severe limitations with sleep outcome measurements prohibiting a strong recommendation. Anyone that does sleep research will know that this is a very challenging thing to do. So using perception of sleep, it's a qualitative measure. There's tons of recall bias of those that can actually answer right. And there's no sleep architecture measurements to say whether they're actually asleep or not. In addition, melatonin is not a US FDA regulated, so quality and quantity may vary. And lastly, there was extreme heterogeneity in terms of dose, duration, frequency, which limits our ability to give you a specific recommendation on the dosing. Lastly, cost and availability may vary by country. So overall, what was the summary of our recommendations? We were unable to issue a recommendation on the use of benzos to treat anxiety. We suggest using dexmedetomidine over propofol if light sedation and delirium outweighs the risk of bradycardia for your patient. We are unable to issue a recommendation for or against the use of antipsychotics to treat delirium. We suggest more is more in this case, so enhanced mobilization over usual care mobilization. And we suggest administering melatonin over no melatonin in critically ill adults. That is it. Thank you.
Thank you, everybody. We're going to hold the questions until the end of the presentation, so that way we can stay on time. And with that in mind. great pleasure to introduce Dr. Amelia Barwise. She is the Associate Professor of Medicine and Bioethics at the Mayo Clinic in the Division of Pulmonary and Critical Care. She also has a PhD in end-of-life disparities in people with language barrier, and she dedicated her professional life to fighting for people who cannot speak on their own behalf. So I will let her work speak for itself.
Thanks very much for that introduction, and thank you for that wonderful talk. Having just struggled through a very tiny systematic review, I can appreciate that as an enormous amount of work that you've completed. Great, so I'm going to be talking about language barriers and humanizing ICU for patients who have different cultures and different languages. All right, okay. I don't have any conflicts of interest. So just to briefly give an outline, I'm going to be discussing a case study, then we're going to talk about decision-making, language and culture in the ICU, talk about the benefits of interpreters and how we can best work with them, talk about a few other strategies to address linguistic and cultural barriers, and then conclude. So our case then, we had a 90-year-old gentleman, Karen, speaking, and that's people from Myanmar who often live in Thailand. It's a sort of an ethnic minority in Myanmar, speak the Karen language. He came in with multiple comorbidities and was found to have a hepatic abscess. He was started on broad-spectrum antibiotics. However, during his stay on the floor, he decompensated and had to go to the ICU. On his 5th day there, he required intubation, and the medical team, and Dr. Ahmed was actually one of his physicians, his lead physician, and brought this case to my attention. The team wanted to discuss his code status, goals of care, and plan post-intubation. And the patient's son did not speak English. His grandson spoke some English, but seemed to have some potential health literacy issues. And they gathered for a family conference and tried to identify an interpreter. But there were no interpreters available either in person or via video or telephone. So the clinician had some discussions, and the family agreed to switch their grandfather, to a do not resuscitate, do not intubate order. But Dr. Ahmed had some concerns about their understanding and voluntariness, given that there was no interpreter available. So we'll come back to the case at the end. So you may have all heard the term limited English proficiency, or LEP. I'm trying to move away from that term now, but basically these patients have a limited ability to read, write, speak, or understand English, or they don't speak English as their primary language. And that's about 25 million people in the US right now, so almost 10% of our population. So the new term that I'm leaning towards is non-English language preference, because this really gets away from our deficit-centering term, and more tries to think about patients in their daily lives and their social context and what type of languages they're speaking at home. And you may also have heard the term PLOE, a preferred language other than English. Some people like that word better. So when we think about culture, there's this idea of the cultural iceberg that was coined by this anthropologist. And we often think of things like flags and festivals and music, food, what people wear. But of course, when we're thinking about how culture impacts the ICU, we're really thinking about these things that are hidden. So it's more around concepts about end of life, concepts about death, what's the role of different people in the family, how people communicate, etc. So that's much more likely to impact what's happening, with your ICU care. And I just want to draw attention to this book that some of you probably know, The Spirit Catches You and You Fall Down. And this is a story of a Hmong child who had a seizure disorder in California, and how her family viewed her seizure disorder very differently from her pediatricians. And so one of the pediatricians wrote this book, and it's a really interesting sort of description of how those two cultures essentially clashed with caring for the child. So cultural humility, and I had reached out to the SCCM when originally the title was cultural competence, and I specifically asked them to switch to cultural humility because I think, cultural competence has been a word that's been used a lot in education, but we're trying to sort of develop more an understanding that people are different, they have different cultures, different beliefs, and really just be sensitive to those rather than trying to sort of understand everything that people might be thinking or know or believe. So we're trying to move away from this idea that we have to be competent in everybody's different culture, but more just be humble in how we approach. So when we think about decision-making in the ICU, we did a study a few years ago looking at the impact of language barriers in our ICUs, and these were some of our outcomes. We had lower rates of advanced directives for patients with language barriers, increased mechanical utilization, low rates of do not resuscitate and comfort measure orders, and longer delays in getting those orders. And at the end of that study, we're really left with, is there a knowledge gap? Is there poor bidirectional communication between clinicians and patients and families? Do these differences, are they differences or are they disparities? It's hard to say from this data, but do these differences reflect authentic and normative preferences or potentially cultural beliefs? Were there some systemic issues going on? Maybe interpreters were not coming to the bedside. But obviously, if we're providing unwanted care that's potentially aggressive and it's not in line with someone's wishes or values or goals of care, then we could potentially be causing suffering. So we need to just bear that in mind. We made a framework then of what were all the reasons for sort of delayed decision-making and differences in decision-making. And there's a lot of issues here that I'm sure many of you recognize. Lack of time, it's hard to get the interpreter. People are very focused on language accuracy. Empathy can be hard. It can be hard just having a third person there, the interpreter. Relationship building and trust is much, much harder. And also then some patients and families don't understand concepts such as palliative care, comfort care, things like that. But then obviously there is definitely a sense that some beliefs, are different around de-escalation of care. And prolonging life and various interventions. So there's definitely a cultural aspect of this as well as the communication with the interpreter or whoever. I also just wanted to touch on truth-telling and non-disclosure, which I'm sure many of you have come across. So non-disclosure is, when a family might ask you to deliberately withhold information because of a concern that breaking bad news can cause worry, harm, or lack of hope. And this is, from our point of view, sometimes looks like it may be causing harm and potentially conflicts with, our traditional notions of autonomy. We also have to recognize that some people prefer sort of a different notion of autonomy, and they potentially hand that over to other people in their family or spouses to make decisions. So it's not really as clear-cut as sort of a clash of these two principles. It's important, obviously, to be delivering prognoses and diagnoses in a culturally sensitive manner. I also want to just touch on, collective decision-making. This can have an impact on shared decision-making. But I think, asking families and patients if they're, able to answer this question, how would you like to receive information about your condition, is one way to start, maybe. So the last 20 years, we've really been focused on shared decision-making, and that was because we had a lot of paternalistic decision-making that swung the other way then to autonomy, and patients were lonely in their autonomy because they were being left to make decisions and not feeling they were getting guidance. And a lot has been written about this in the oncology literature, not so much in critical illness, but it started out, I just wanted to point out, with this Italian doctor, Antonella Sorbonne, and she was working in the US in the 90s, and when she went back to Italy, their ethics guidance actually at that stage said, do not share a bad diagnosis with the patient, and that was in the 90s in Italy. So we often think of this as being like an East-West thing, but it's not always. Obviously, Italy has changed now, but so it's just to point out that there are just differences, and not everybody was following in the same way that the US was here, even in the 90s. And just to point out then, this is an example from an author from Taiwan, and just trying to articulate why truth-telling can be harmful, or is perceived as harmful. The family are a key player in any medical decision making, and harmony is very essential. So when there's bad news broken, that sort of disrupts the harmony. There's taboo as well then about talking about death and related issues. And they're really emphasizing in this idea of doing no harm, even if that does come into conflict with telling the truth. So just moving on to interpreters, because I'm a great believer in interpreters in the ICU, because patients have very complicated things going on. And I really think in-person interpreters can really help, but patients are also entitled to interpreters. There's many, many executive orders and federal laws and state laws that entitle them to interpreters. And these can be in person, virtual, or by phone. Translators translate written documents, and interpreters interpret spoken word. And they are more accurate than ad hoc interpreters or family or someone you pull in who's maybe done some high school Spanish. They have professional tenets that they abide by, confidentiality, accuracy, and they can mitigate many of the risks for patients, because patients who have language barriers are at risk of actually adverse outcomes, not just in terms of their actual decision making, but other adverse outcomes. And so interpreters can really improve outcomes for these patients, but they do have variable training. I just also wanted to mention that this idea of the triple threat, which is along with these cultural differences and language barriers, sometimes there is the associated health literacy barrier. So those are three things that come along together and can be challenging for clinicians to help manage. And an interpreter really can serve several functions in the ICU, not only doing the verbatim interpretation, but also acting as a cultural broker. I'm sure many of you have heard of that, as a bridge, help fill in the clinician with any cultural perspectives that might be relevant to the decision making. And they can also serve then as a health literacy guardian and help advocate for the patient, make sure they're understanding, and help the clinician understand what the family has understood. So if we want to really work well with interpreters, there are, some really basic things that we can do to really enhance our discussions with our patients. And this is in many, many articles, but really try to meet your interpreter before. I know everyone is really busy, but that 5 minutes could really help make everything else go more smoothly and potentially save time in the long run. But really try to meet the interpreter before, fill them in on what is the medical background, what's the decision you're trying to make today. And just recognize they don't always have access to the medical record. That's very institutional dependent. And if they do, they may not have time to look at it, or they may not have the knowledge about how to delve into EPIC to get what they need. So I think if you can meet them and just give them a 5-minute sort of synopsis of what's going on, that's really, really helpful. And the interpreter can also actually help clinicians a lot, which I'll go into in a minute. During the discussion, short sentences, no jargon, no humor, no idioms. And then afterwards, it's really nice if you can debrief with the interpreters. And this can help with moral distress and vicarious trauma that they often experience. And they don't necessarily have a team that they can sort of chit-chat with during the day to talk about cases and debrief. So we designed this check-in guide that we're currently testing right now in a simulation environment. And it's just to try and give some little sort of pointers to what kind of things you can be discussing with the interpreter before you have your family meeting. So just giving them, as I mentioned, the purpose of the meeting, what's the medical situation, and then the interpreter can potentially fill you in with social implications and cultural aspects of care and beliefs. And then you can make a plan together with how best to have this discussion. We just completed a study in October where we tried to improve the use of in-person interpreters in the ICU and among patients with complex care who are in the hospital for a long time. And we did this by nudging clinicians. So we identified using an algorithm who was a complex patient who had a language barrier, and then we sent a secure chat to their bedside nurse, just saying, hey, we really think your patient would benefit from an in-person interpreter. Here's how you contact us. And we did show 40% higher odds of receiving an in-person interpreter among the people who had the intervention, and we recruited over 1,400 patients. So we didn't quite reach statistical significance, but we're very excited about the results. And actually our language services are continuing this secure chat because they really like it. I've also been working with Luda and Samir on the Get to Know Me board, which is one of the approaches we use in Mayo to humanize ICU care. And we've done a few studies on this, and we've shown it supports relationship building with patients and families. Patients like it, clinicians like it, and it really tries to encourage the team to think about the patient in their everyday lives. And in terms of patients with language barriers, then we've just started some other work trying to fill in the Get to Know Me board and using a large language model that can actually work with patients and families who speak different languages to help get this filled out. Of course, what else are we doing with AI? We're doing an exploratory study right now comparing some of these tools. So one that's been developed at Mayo, AI Translator, and comparing that to ChatGPT and potentially Google Translate, and giving it some critical care scenarios to see which one is most accurate, most fluent, which is most usable, things like that. So back to our case report. On day 3, we were able to identify a Karen interpreter. The family reaffirmed their decision to switch to DNR/DNI. And the clinician felt good that it was voluntary, and this was definitely in line with their beliefs. I should also note that clinical ethics were sort of involved in this consultation. A chaplain was present, really able to support that this was a faith-based decision that the family were making. Just a couple of other things I want to touch on. I'm nearly done. So culture vision is something we have at Mayo, and I don't know if it's an institutional license, and basically you can put in different ethnic groups or different religions, and it can give you background about those groups, as well as around death and dying. And although this is probably not so much ICU, but more longitudinal care, something that builds on the interpreter idea is this cultural mediator. So I really just encourage people to leverage interpreter skills if possible, listen to family if there are disagreements about bad news, find out how people want information, consider involving a chaplain, and then some of these other things like nudges, advocacy, promoting interpreters. And I haven't touched on any cultures, Native American culture. I haven't touched on Jewish patients and things like that. They obviously have their own needs, but patient relations specialists can sometimes help fill that gap. Sorry, thank you.
Thank you so much, Dr. Barwise, for that great talk. In the interest of time, please save all your amazing questions. We'll go to the next presentation. So it's our pleasure to introduce Erika Setlif. I said that right, yes. She's one of, yes. She's our clinical nurse specialist who supports critical care practice in the southeast region of Atrium Health through virtual critical care. And it has been some of her interests to study workplace violence, resuscitation, quality, clinical deterioration, and early detection, and a lot of work on ICU liberation. So excited to hear from you, Erika, please.
Good afternoon, everyone. And it's really fun to see some familiar faces and some really old familiar faces. So good to see everybody, and thanks for being here. So the talk that I was asked to give centered around humanizing ICU care through a lens of bundle implementation and quality improvement. And so I appreciated that focus. This is me and the things that keep me grounded in my humanity, my 4 kids. I have no disclosures other than I am super passionate about ICU liberation, and so they gave me a space to talk about it, and that means I won't shut up about it. So that is my only disclosure, is a great deal of passion in this space. Just wanted to take us to some of the rooms that we care for patients in on a regular basis. And as I think about the care of the patient and all that goes into the complexity of what we do, it can feel a little bit like Where's Waldo, to remember that there is a patient kind of hidden over there. You can see him if you look real close through the pumps, and there is a patient at the center of what we do in our care. And I think about how easy it is to go through a shift where I have done a thorough head-to-toe assessment, I've assessed pupils, but have I made eye contact? I have assessed pulses and palpated and done all the things, but have I made that human connection? And so as we think about what it looks like to bring that humanity back to center, I think a lot of us lived through pandemic era, and so we have visions of what ICU care we don't want, and things that we know we've lived through and would rather not revisit. And so with that in mind, I had thought through, if we're talking about humanity in critical care, what would make something inhumane? And it is without compassion, it is without human feeling, it is causing suffering, causing pain or heartlessness. And so thinking about ICU liberation, I see a best practice bundle recently updated that just continues to put our focus back on putting the humanity back into patient care and removing us from the things that take patients away from humanity. Over sedation, being confined to bed, not being able to speak, not being able to interact, experiencing pain and suffering. And our goal is to step in through this bundle of best practices and pull our patients back out of that, combat the things that are negative about the care that we do have to do to get our patients through critical illness. It is not that our interventions are bad, but they do inherently carry risks with them. And so I think about humanity in critical care and try to picture what would that look like. And I think that as we look at bundle implementation, that really gets us where we want to be. So I'm going to assume that everyone in here is somewhere on the A to F bundle, A, B, C, D, E, F bundle, ICU liberation. I use these terms interchangeably, but we are somewhere on the journey. I'm going to assume that you have a sense of familiarity. Certainly, if you didn't before, you do now through the PADIS guideline updates that we heard about. But just think about putting back in the center of that humanity, which brings us back to the core of what we're doing. Not to add more letters, because I think we could easily end up as the A to Z bundle, and then we'd lose people halfway through, but just remembering that that patient is at the center of what we're doing. So as we've learned, there's been an update, and if you didn't get the QR code before, you have it now. So we have more than 10 years of really robust data and study around what we should be doing through the PAD guidelines, the PADIS guidelines. Now with our new update, we know what we should be doing, and I'm really encouraged to see how we're now building on some of those foundations. We're assuming that mobility is happening. We don't have to tell people mobility is a good thing, and we're saying now enhance that mobility. So I love to see that we are growing and have moved even, I think, the culture of what we expect our units to be. I see Kelly Dayton in the audience and just love the concept of the awake and walking ICU that she talks about a lot, because I think that's a really good way for us to kind of hold your thumb up and say, okay, yep, we're on this side or we're on that side of it. It gives a vision of what your ICU should look like when we think about what does it actually mean. Because I think when we talk to people in the critical care sphere, people say, oh, the A to F bundle, yeah, is that like getting the patients off the ventilator? Yeah, we do that. So I think we hear a lot of that. I certainly do. And I would just remind us that without data, you are just another person with an opinion, self-included in that. W. Deming is really big in quality improvement, kind of the father of quality improvement, process improvement. But with that, there was a 2022 survey needs assessment done through SCCM of our members, and most of those said that they did not measure bundle compliance, or they weren't sure if they did. So if you don't know if it's measured, it's functionally not measured, because it's not getting to the people doing the work. So it brings us to, what does quality improvement look like for critical care, and how do we keep that centered where we need to be, which is on our patients at the center. And so I thought about it through this lens, because I think at some degree we have concepts of quality improvement. If that's something where you're really trying to get started, I'd love to connect with you offline. But I kind of wanted to think about this through the lens of, if we're bringing it back to what does it look like to have a meaningful measure of humanity in our care, in critical care, what does that look like? So thinking about the bundle as A, assess, prevent, and manage pain. We know this one. Yes, we know that our minimum data set has us assessing how frequently are we assessing pain? Are we using validated tools? Maybe in your ICU, you want to think about not just are we assessing, but are the patients actually where we want them to be? Are they awake? Is their pain managed sufficiently to engage in care? How could we look at that measure kind of at the next level with that? Both SAT and SBT. Everybody knows we got to do daily SATs and SBTs, right? Till we are tired of talking about it, but guess what? We got to do them, and the data shows that we're probably missing SATs on patients because we have screened them out using an exclusion criteria. So is your team looking to say, I got to document to the metric and exclude, but at least my percent looks high because I have assessed everybody? I can tell you that I have personally worked with a team whose dashboard looked beautiful because we were 100% for assessing every patient for SAT compliance, which meant everybody got a safety screen, and only 3 patients made it past that safety screen in 1 month in a large ICU to actually potentially get an SAT, and I think 2 of the 3. So they were 100% and a 66%, but that was 2 patients who actually had an SAT done. So look at your numbers with this and look at the reasons why people are excluding to say, if I have so many patients who are excluded from this process, have we really reached our goal of reducing sedation, bringing those patients back to reality, back to interaction, and keeping them humane in our care? So protocolized is important, but also personalized, and thinking about the ways that we can do that meaningfully for patients. I'll give a brief example here from a clinician I work with who had a very rowdy patient who was going through his SAT and went to put on some of the nice calming music that we get through our hospital TV system. And the wife of the patient burst out laughing and said, "That's not going to get you anywhere." And what she learned was this gentleman was a big fan of heavy metal. And if you put on the nice, soothing, angelic bells, that was not going to make him calm. And so instead, they Googled and found, I couldn't tell you the bands, I'm sorry. He chilled out, the sedation came off, and they were able to extubate that patient because he was listening to something that was calming for him, not something that fit the "we are going to calm you" protocol. And so think about how we customize. The framework of liberation gives us a model that helps us to customize within it. It's not to say absolutely every patient is going to fit every part of this mold, but when we have a pattern and when we have a process that we do consistently, every patient, every day, it allows us to have then those conversations about the outliers within a framework. It lets us focus on the implementation instead of having to approach every patient and figure out, are we supposed to do a breathing trial? Are we supposed to move forward? We have those frameworks, and it allows us to focus on the person inside of that. So I will just also throw in with SAT, SBT, consider paralytic de-escalation as part of your process because that's one of those exclusion criteria. But if you don't have a process for de-escalating paralytics, you miss that entry into SAT, SBT. And I think there's probably opportunity to move a little further along, a little earlier for some of our patients if you're not really looking at paralytic vacations along with this process. So think again about metrics and measures. Choice of analgesia and sedation. So yes, I think kind of our standard measure here, frequency of RAS or SAS assessment, but also, do your sedation goals make sense? If you're assessing regularly and have deeply sedated patients who are not interactive and not able to participate in mobility and not part of the team when they really could have been progressed, look at your percent of time at deep sedation and consider that as maybe a metric to work on in your unit if that's something that you find your culture has a deeper level of sedation as a target. Think about time and goal range and duration of those goals. And then I just threw in a little blurb here about the updated guidelines with dexmedetomidine as a new recommendation for those light sedation patients, or if you have really a focus on reduction of delirium in your unit. So maybe consider that as well as you think about your order sets and kind of first-line agents if we're really looking toward a light sedation patient, which ideally most of ours would start there, just throwing that out there. So moving on and thinking about other meaningful measures. Some of this you can't get from a chart. So yes, assessment. Are we regularly assessing our patients? What's our % of delirium? But think about other measures within your unit that you can look at. Do we have standard prevention in place? I had a quality project where they literally, while my nurses were working, would track how many TVs were on past midnight and tried to reduce that and pushed for a quieter ICU because turns out Jurassic Park, when you're on sedation, can be a little disorienting. So having the TVs off. Some of this challenges our paradigms too. 3 a.m. baths are great for nurses. It's very convenient in our workflow, but it is not good for quality sleep. And thinking about when are we going in and the x-ray board, okay, now we're going in for labs. Those things are very disruptive to sleep, which we know progresses our patients toward delirium. And it's not about a medication. It's just that we have our structures set around our convenience instead of our patient at the center. So think about challenging some of those paradigms in your spaces. Love the terminology around enhanced mobility. So totally have already updated all my slides and every talk I give about liberation ever because early mobility was good, but it implied we were doing something above and beyond. And so if you're busy and you're like, well, the early thing, maybe we don't get to the early mobility, we'll do our normal stuff. So I was never a big fan of the early. Enhanced mobility, love it. That's where we should all be. Wherever you are, get it to the next level. Yes, we need a safety screen and mobility performed, but think about that next level with your patient. Is the dangle the measure? Or if this patient's able to be ambulating and they dangle, they might meet for your dashboard, but have we really progressed and advanced and enhanced that patient's mobility to that next space? So some of this is challenging to implement as someone who has been building a dashboard for a large organization and trying to customize. This is challenging, but it can also be done small scale as you work with your units. And then finally, family engagement and empowerment. This is huge, but it's a really hard metric to track. So even in the world of quality, not everything has to be in a graph. Think about measures for your team like, do we as a facility, do we as a unit engage our families in rounds? Do we as a unit measure things outside the EMR like unit policies? What do our policies look like? How are we approaching families? And can we build some measure around that? How are rounds structured? What's our approach? Do we have options for families to engage in care meaningfully? So giving some, yes, we've got to have some kind of measure to track. I'm the queen of data, so I feel like I'm talking out of both sides of my mouth saying we've got to have data, but also think about measuring beyond that so that we're not just coaching to our data. So just thinking about quality improvement approaches, I would say ask honest questions of yourself and your team and hold up that measure and say, is this an ICU that we feel is liberating, that is putting humanity at the core, that is putting our patients at the center where we want them able to interact with their families? We are not taking away their humanity by sedating them when they don't need it, taking their voice when we could move them toward extubation with standard processes and measures. A couple approaches, again, I assume everyone is somewhere on the continuum of implementing with this. Start with one patient and do all the things and learn and disseminate and talk with your team, bring it back to huddles and talk through and begin to expand, or you can approach it letter by letter. Lots of different ways. Set your measures, work with your teams, get your stakeholders. But as you work on each element, you're gonna find a lot of overlap. Get your champions involved. Really, we've found that administrative buy-in and support is a huge facilitator of bundle adoptions, so engage your key leaders. Tie it to those patient stories and outcomes because that's what ultimately connects us back to the why in this work. Data and context, I think, is huge. There's data, and then there's data that means something. And then also an eye to sustainability. So just as we close out, I just want you to think about what would it look like to really have ICU liberation driving that concept of humanity in the ICU and bringing our patients back to where we want them. Thanks.